I'm here. Can I start? Okay. Good afternoon, everyone. I know everyone was waiting for this moment. It's a great moment for me. It's the first individualized talks that we are going to start. And the first one is with my closest friends. We are almost family. We are even from one. I am even a neighbor of him. So it's really a great pleasure. They are here from the very beginning. Uh, they have been from with the Bonisi from the, the primordial times. So it is really great to be with them. So guys, this is my superheroes. Welcome to my superheroes, José Figueiredo and Luís Mesquita Santos. And my first question to you is, when did you start to doing these individualized solutions?
Hello, Rui.
Hi, Rui.
The hero is you, not we and Luis. Me and Luis.
Yeah,
okay.
Really true.
So we started using individualized implants in 2018. At that time, we were still using the hybrid implantize. The system has evolved, and in the meantime, we have reached implantize compact, which is the implant we currently use. As we can see in the follow image, we will pass an image. The hybrid implant.
Perfect, Rui. Yes?
Yes, we can
you
see
the image? Okay, you have in the left an hybrid implant and the right a compact implant. Okay. As you can see in the follow image, the hybrid implant was made in a single piece for full arc, and the compact is made in two pieces, which makes its surgical placement and sitting in the bone much easier. Implantized compact features improve the biological principles, much more robust zygomatic fixation, greatly minimizing the complication we had with implantized hybrid.
Okay. In which cases do you? What are your tools for these types of cases? I imagine that you use these ones only in very big atrophic cases.
Yes, right, Roy. In the upper jaw, there are several possibilities for the rehabilitation. This kind, the maxillas and the mandibulas. Me and Jose, your philosophy is graftless. Okay. You can use the zygomatic implants, the pterygoid implants, and in some cases in short implants. All these techniques have their limitations and difficulties, and depending of the clinical case, you still use every one of them. However, because Implantize is programmed and designed digitally, I think it is the best solution in most cases. Okay. In many times, me and Jose combined the mix with Implantize Compact with pterygoid implants because, in my opinion, and Jose, is harder to increase the stiffness of the structure, and especially in the patients with the bruxism, to show it the present the very strong in the muscles, the when talk, when hit, when smile. If we talk about the trophic lower jaw, the only solution, in my opinion, is the best solution is placement in the individualized implant. Look and
we have a video.
Yeah, look the video.
Show you.
Yeah, show you the idea we're talking about.
Where our video?
Okay.
Wow.
Okay.
These patients have 4 times the treatment Holland 4 and the lost whole implants in the whole times. Okay. Look the video, and when me and Jose performed the surgery, this surgery was performed in the general anesthesia in hospital. This point, radial pack point, it means reverse planning for the prothesis. Okay, look the oral view, and look the planning, the case with the company. Look the reverse planning for the emergence of the screws, the correctly positions.
The main stress was remove that implant that stayed in the mouth. The risk to broke the jaw, it's very high. This is
yes.
the implant.
Yeah, look the correct position, the screws very close to the mental nerve in the alveolar nerve. Okay. I started with the incision, the middle incision of the crest. Okay. In this part, be careful because the emergence of the mental nerve over the crest is very typical in this kind of case.
Yeah,
In this part, me and Jose isolate the nerve and the perineuro around the mental nerve. Now remove the implant dentistry, and clean this area. Now I cut the periossal in the zone for the freedom, the flap, the lingual flap, and cut again the periossal because I need the total freedom, the buccal flap. And this part check the correct position, the implant over the bone. And now put the first screw in the middle zone, the middle zone in this case. Very hard, this only cortical bone in this mandible.
We don't need the preparation to the connections because the heart is very
atrophic.
Yeah.
The other side, the left side, start with the incision, the middle, the crest. Be careful.
Be careful
because the emergence, the nerve, okay, and create the flap, the same thing, and shows the emergence, the nerve, and again create the cut of periosseum and isolate the nerve. Look, the mental nerve. Okay.
It's coming from behind it, so you
put the implant.
You have made a small deviation also in this side.
Sorry, Rui, we can't listen you.
I said the nerve has made some deviation because it didn't have the roof of the canal.
Yeah. Yeah, the pure, the bone. There are in this zone the little cortical, but more posterior area. Now put the abutments, the multi-abutments, and L cups. Now is a cut of periosseum. or create
elasticity in the gum.
And start the suturing.
And in this case, for us, is the only the solution. We can't use short implants in this case. We think.
In this case, use the simple suture and the apical matters or colchonaire horizontal. And look, this is a CVCT post-op, and in this case, I have a immediate loading. Okay. After the patient, other day, the surgery returned the clinic and put the prosthesis. Okay, the temporary prosthesis. Sure, this is the aspect after 2 months.
2 months, yes.
After healing, this is the in-depth loading. Okay, the temporal prosthesis.
Without pressure in the tissue, we don't need the pressure in the tissues because we have no keratinized gum. Okay, look at the gum in 4 months. Yes.
No, this picture after maybe 9 months, 1 year maybe. Yeah, this is a CVCT after 9 months.
It's perfectly adapted. The bone.
Yet no have lesions. Okay, not kind and small or on big lesions. It's not there.
That's because it's a negative crest.
Yeah. And other things.
Mm-hmm.
Okay.
And that's it.
Okay, and so I'm curious about something. I would like to know what is your workflow, meaning when do you think you should start with this solution or the other solution or individualized solution? What is your idea? Do you think you go first for short?
Whenever there is enough bone to place conventional implants, this is our first choice. When we have a bone, crest bone, we use conventional implants. Okay. When this does not happen, we feel more comfortable with these individualized implants since we are able to program the position of each screw and each connector in detail, greatly reducing surgical stress. Nowadays, there is even the possibility of having the patient's prosthesis ready to be screwed and inserted before surgery, which is fantastic.
Okay. Another question. We have all been involved and with some other guys on the what we call the muscle skeletal integration concept, the MIC. Can you tell us a little bit more about what is this concept?
Yeah, the MIC is the fantastic concept and the great concept. Typically, in these bariatric cases, we completely lose the alveolar bone and have work with no keratized tissue. The muscles insertions are very close to the bone crest. This makes it difficult to perform gingival grafts, as it's very difficult to sterilize this tissue, these grafts. It means in this sense, he understands that you have a connector, that connector with the prots is non-keratinized tissue, as long the implant fixations are in the regions protected by the muscles. Since are starting designing in the implants, these implants, following these principles, I have greatly minimized the problems appear from lesions that involve exposures, the screws and fiction, the structures. But look this video, and this video explained perfectly this concept. Sorry, and look
here.
Look this insertion, these muscles, the master muscle, the buccinator, and the mental muscles. And look when me and Jose and the other guys choose the correct position for the placement, the screws. All screws under the muscles. If you put these screws in this position, is not probably to have expositions and failure the integration these screws. This is a secret, okay? This is a secret, and this is concern. This the musculoskeletal integration, the MIC.
Okay. Can you tell me one other thing is that everyone look at us and say, oh God, there comes again the subperiosteal. Everyone wants the whole the things. It's the whole coming back again. Do you agree with this, or do you think there is different concepts on this?
Very different concept.
Very different, yes. So first point, superiosteal implants are not medical devices, okay? They were made of chrome or cobalt, have no fixing screws, etc., etc. These new implants are made of titanium, have SLA surface treatment on the face that touch the bone, with all the advantages that come with it. Have fixation screws, also with the SLA surface treatment, and designed with using tomography, okay? Preventing a first surgery to print the bone, like the superiosteals. However, all implants are subject to a fitted elements study in order to guarantee its resistance to chewing forces. The manufacturing process is very rigorous, complying with the most damaging standards in order to be approved as a medical device by most countries in the world. Okay.
Okay.
Implants are so different from the whole superiosteal implants that we even like to call them short implants with distant fixations. Okay.
Okay. So you guys are already on the 22nd, I think, course that you are giving of this. So I imagine lots of people that are assisting our live wants to know a little bit more. What can you tell to people who want to start to make this system?
Yes, it's true, Rui. 21 course already. We coursed with this kind of the implant. So, who wants to start the first has to like this kind of surgery and rehabilitation. Then they just needed to have some experience in manipulation of soft tissues and have two necessary handles to achieve the good seats of these implants over the bone. Okay, is most important factor for us, and in your main message in each course he teach. Excellent seats are the secret for the success of these implants. These surgeries require large detachments, large flaps. Anyone who is comfortable is ready of kind of this surgery, not problem. It's more easy, in my opinion, it's more easy of kind the zygomatic surgery. Okay.
Okay. And another thing that everyone wants to listen for sure when we are talking about new solutions, everyone wants to know what is the main complications that you have with this system.
As we said in the previous question, when we do not achieve the correct sitting of the implant in the bone, we are increasing the change of the implant moving in the short term, and it may even fracture. When this happens, we have to remove it and install another one. Another complication that can occur is dehiscence, resulting from the non-existence of keratinized gum. The implantized compact had some improvements that helps to minimize this problem, like the placement of the fixation bars in an area more apical to the connector, and the existence of a small hole that allow the soft tissues to be fixed to the bone through the implant. You can see, not in this image, in this image, upper the connector, the anterior connector, we have a little small hole. Is not to insert a screw, but to allow the fixation of the gum in this point.
Yes.
So with this, the dehiscence practically not occurs. Okay.
Okay, guys, very good. Let's see if we have some questions. We have here at least one question.
I have. What was thinking in your head the first time you did the implantized hybrid? What was going on? It was like, were you terrified that we were going to screw the woman's life or the patient's life, drilling all of a sudden? You know, what were you thinking?
When started with Jose the placement, the implantized hybrid, we would like these implantized in one piece beginnings create many complications into the surgery because look and think is more difficult put the same time the correct position, the left side, the other side is the mainly problem maybe.
Yes.
Okay. Nowadays with implantized compact, not this problem. Okay, but probably in the start.
Yes.
Implantized hybrid
difficult.
is the main problem because the passivity of the bone with the implant. Okay.
The settlement is more
yes,
difficult.
more difficult in this case.
Very
But
huge framework, right?
yes. The screws in this kind, the implant hybrid is more short. Yes.
Yes.
Not problem when put the placement to the screws. Maybe these problems. No.
Yes.
Okay, guys, it was terrific to have you here. You know that I'm your fan, and you are all of the superheroes that works with Bone Easy, one of the ones that work more. And for the people who assist, I want to tell you that very soon we will have another one. So you should look at our social media because very soon we will announce another talk, individualized talk. Okay, guys, thank you. Okay.
Thank you, Rui.
Thank you.
Thank you. Bye.
Okay. Bye.
Bye.
Okay, so Rui, tell me, how is it your first experience in the what? Sorry, it was not a question for you guys.
want to hand it here.
Yeah.
Right.
I want to talk to you, Rui.
Okay.
So, guys, we're gonna have a little talk before we end with Dr. Rui and me because I'm going to make my way into this. I don't know. So, Rui, tell me, what was your first? How does the implantize came to life? Like, what was your idea? Were you struggling with it while you worked as a dentist?
Well, there was more than one thing in reality. First one, I was a zygomatic implant user. So I felt that was something that could go a little bit wrong about the mechanics, okay?
Yeah.
Mechanics about the zygoma implants, the longer ones, they have this problem which is bending. It was something in my mind that I have to stop it that, because if I have micro movements under the periosteum, this will generate bone recession. That's what's happened. That's the big story around the subperiosteal implants. Because, for example, when we are talking about subperiosteal implants, the main failure is because they move a little bit, and by moving, they made these huge resorptions, bone resorptions.
Yeah.
So the same I see if the zygoma implant starts to have some bending, and this micro movement generates also, like the ancient subperiosteal, generate bone recession. So for me, my goal was to get an implant that could not have
Bone recession.
that could not have bending.
Yeah.
Micro movements kills bone. Okay, the main principle that we use today is osseointegration, thanks to Dr. Brandmark. And bone and the osseointegration, it's our goal. It's to have an implant that doesn't have micro movements, and by not having micro movements, we can achieve bone integration, osseointegration around the implant, and that makes him biological more acceptable.
Oh, very good. Thank you so much. Also, I would like to ask you, what was it like designing the implant, knowing they could not have tension between the muscles? So when you do an implantized, compact or hybrid, you have to pull the muscles open, take it all, and then put the implant, right?
That's it. We didn't invent anything. Okay,
Yeah.
That's the main thing. So what we pick, it's two concepts. Okay, we pick from one side the concept of LeFor1, okay,
Yeah.
and plating LeFor1 fixation, and we just adapted small things to be able to load the plates instead of loading the bone. Okay, that's the main difference. But on the inferior, what we did, it's a concept that has 46 years, it's Champi plates. Champi plates changed the world on fracture fixation of the mandible. So if you want to know something more about, you just read about Champi plates, Champi lines, and you will see that you will find the implantized compact as a replica of this concept. So thanks to Dr. Champi.
Oh, very good. Thank you, Dr. Champi, for making us do this. What was the first problems? What was the first fix?
Yeah, foolish from our side. We thought that it was just picking up an old concept and do it in a fancy way. On the end, it was not like that. We have learned a lot. So the main problem that we had is always loss of fixation. Okay? So we pick up. It's different to load plates and to load bone. So something that we completely banish. Okay? With the new system, we never had it. It represented about 9% of the case of failure case of first implants. Okay?
Oh, okay.
Now it's 0.
Wow, from 9%, that was a small percentage. That to 0 is very good.
It's on the fixation. Of course, we have other complications. It can occur, other like fractures occurs to everything. But in reality, This one is something that we solve very well.
Do you think that we lose fixation because there are people that have a bone structure? And by the way, I'm very not in the area, so pardon me for my ignorance. Because of porosity of the bone.
No, it's the type of screws. It's the long of the screws. It's to use screw lock and other things.
Oh, okay. For example, I've heard that when you do implantized compact, I'm not saying that it's going to be, for example, implantized compact, but a lot of doctors prefer bicurticais.
Bicortical, yeah.
Bicorticals. Can you explain me why that decision?
Well, bicortical, it's the principle of zygoma implants, for example. If you got bicortical, it's different if you put here only a screw or if you pass it on the other part. So this is bicortical if you pass on two sides, okay?
Yeah.
If you pass it on two sides, it will have much more stability here, because you will have 2 points where you can fix the...
Okay.
That's it. So we changed some things, but I think we'll talk about this in the future. There will be more chances on the another individualized tasks.
I'm glad. I think this was a nice start. Just wanted to give you a few on the spot questions. But yeah, I liked it. Hope you guys liked it too.
Well, and see you next time, okay? Bye.